So now I invite Dr. Niranjan Karthik, who's practicing with us, to talk to us about how to assess a patient plan for daycare eye surgeries. This is very, very important because mostly we focus on ophthalmic assessment, but it's also important that we focus on general well-being of the patient and do a proper general examination and document it. So over to you, Dr. Niranjan.
Thank you, sir. So at the outset, I would like to thank Nirmal sir for giving me this very valuable opportunity and AIOC for allowing us to present this instruction course. So after the broad overview from sir regarding how to save a sinking patient, now let's move on to a very focused area of how do we go about assessing a patient who's been planned for daycare surgery and cataract surgery in particular. So nowadays we all know that everybody prefers daycare surgery, and though it comes with its perks, it's very important to not miss out on the important drawbacks that it has as well. So overall agenda is to describe and define what a daycare surgery in opthal practice is. How do we prioritize the different sets of patients? Who is fit for daycare surgery? That is going to be the heart piece of our talk today. And pre-operative evaluation, and what are the goals we try to achieve by doing this proper assessment. So we'll start with the definition, which very much has the essence of it. So the daycare surgery or ambulatory surgery refers to the practice of admitting the patient on the day of surgery after being carefully selected and prepared for a planned non-emergency surgical procedure. Now this is very important. The reason I've highlighted it is the careful selection and planning that goes with it. So what are the benefits of doing this daycare surgery? So you avoid hospital-acquired infections due to prolonged stay, more personalized care, and recovery in a familiar and a home-based environment, low complication rates, and higher patient satisfaction because they usually do not like to stay in the hospital. Now what are the benefits for the hospital? Lesser cost and lesser requirement and demands on the nursing staff. So they don't have to maintain longer records and take care of the patients for a longer duration. And in fact, this doesn't bring in the equation of this bed availability and so on. So more number of patients can be treated and served. And overall, as the healthcare system goes, it reduces the burden of the costs for the healthcare system in general, and it is now being preferred by even the government and the insurance companies to have daycare surgeries because that entails lower costs. But what are the drawbacks or the pitfalls? Now, there is a discontinuity or an interruption in the care because the patient goes back home and they can have some sorts of episodes of pain and whatnot. That can be a drawback. Second is chances of missing on detecting early post-op complications, and last but not the least, poor compliance to drugs. Now, having known the advantages and disadvantages of daycare surgery, who are the patients who should be prioritized for this particular daycare surgery? So, infants and children, they are broadly referred to as a vulnerable patients. So, that includes infants and children, patients above 65 years, those in pain, pregnancy, psychiatric disorders. So, these are the three P's that you need to remember: pain, pregnancy, and psychiatric disorders. Multiple chronic comorbidities, trauma, and lastly, blindness. Blindness referring to non-correctable blindness, which can lead to risk of falls, etc. So these are the patients whom you need to be very concerned as far as prioritizing for daycare surgery is. Right. So how do we know who is fit and who isn't? So to start off, like sir had mentioned, the baseline or the foundation is with the fitness with ASA, that is American Society of Anesthesiologists classification. So remember that class 1 and 2 are quite compatible with daycare surgery, but as we go higher in the grades, we need more assistance from the physicians and the anesthesiologist. Physiological status and the fitness should be more personalized rather than considering an arbitrary number of age. So that is very important because people who are 70 can also cooperate for a daycare surgery if they are physically and emotionally fit. Then comes body mass index, which we'll be looking at as an important parameter. And one important thing is, it's not about whether the patient is diabetic or hypertensive, but the stability of the condition that he suffers from. So if he is a patient who's been maintaining his glycemic levels quite well, he can very well be a good candidate for the daycare procedure. So, to condense the big table that we just saw about ASA, this is a simplified version. ASA 1, normal healthy patient, or 2, that with mild systemic disease qualify for a good, comfortable daycare surgery. Whereas 3 and 4 with severe systemic disease and that with a constant threat to life, they need a very good support from a physician or an anesthetist. So now is the BMI. See, we need to remember and should not forget the fact that most of the cataract procedures or any procedures for ophthalm is done in a supine position. So it is very important for the patient's body to cooperate with us for that period of time, right? So one of the parameters which is important is the BMI, body mass index. So more than 50, they are at a very high risk of having issues while during the procedure, whereas less than 40, they are pretty much okay with cooperating for the procedure. Now this 40 to 50 is a gray zone where we need to consult with a good physician and take their confidence in order to proceed with the surgery. Now we'll move on to the exact checklist of what all we need to look at. First, history, general and systemic examination, followed by ophthalmic examination, lab tests, and finally the expert input and the consent. So what are all the key factors which we should not miss? I think that's an easy way to go about it, is to not miss out on the existing comorbidities not commonly found in clinical practice, like thyroid disorders, history of seizures. We tend to miss out on such simple things which can make things very bad for us during the procedure. BPH, like we know about floppy iris syndrome, right? So these are some important histories which can lead to a very complicated or a prolonged procedure time that can again worsen the outcome, right? And not to forget the cervical pain and obstructive sleep apnea. Now, these are two important things because the patient needs to cooperate with us during the procedure, and cervical spondylosis is one condition which makes it restless for them, right? And obstructive sleep apnea can be disastrous because that can have a lot of implications if the patient is in supine position for quite some time. Coming to the medications part, we should not forget that eye is a part of the body and we should treat the body as a whole during the procedure rather than just focusing on the eye. So people who are on blood thinners like aspirin, clopidogrel, they have to be stopped for at least 7 to 10 days prior to the procedure, and ticagrelor, which is a more recent congener, that can be stopped only for 2 to 4 days. Very important part is the low molecular weight heparin bridging for patients who are on acetrom. Those patients who are on acetrom for IHD and so on, they need to be properly moderated and titrated with the bridging before we proceed with cataract surgery to avoid any complications like hyphema or expulsive hemorrhages. Now, general examination, we all know pallor icterus cyanosis. Though we know it, how often do we do it is a big question to be asked. And two important factors which I would like to highlight is the ambulatory status. Remember, we're talking about a daycare surgery, so we need the patient to be restored back to their original state of life at the earliest. So that is one important factor. And hydration status is important in order for the patient to have a good recovery post-op. Lab investigations, the usual investigations like HBBs, TCDC and blood sugar. What we need to focus on is the coagulation profile. Like many patients feel aspirin, clopidogrel is a part of their diet rather than medications and don't tell us the history. So these are some factors which we have used to pick it up in patients who haven't disclosed a good full history of their medications. And to prevent last minute chaos, we have to take the help of an anesthetist or a physician and make sure that the checklist that is required for managing emergencies like oxygen cylinders, nitrogen cylinders, and all of them are proper functioning use. So that is very important to ensure it before the start of the OT session so that we can be in a position to manage chaos. And surgical safety checklist, again to avoid any unnecessary complications post-op like endophthalmitis, make sure that all of it is in place before we proceed with the procedure. So these are things we need to do on our side and not just the patient side in order to ensure a good procedure. And last but not the least, though the patient might have been perfectly fit before the days of surgery, on the day of surgery it's very important to alleviate the anxiety and stress that goes with the pre-op day or on the day of procedure. So it's important for the physician to spend some time to alleviate it before we go ahead with the surgery, because that itself can shoot up the BP and cause whatnot as a complication. To summarize, a very good rapport with the patient and the attendant is important, and very important to explain the importance of the general physical evaluation, because they feel it's okay to live with diabetes and hypertension, but only do we know what it can do to us, do to them during the procedure and to us as well. Optimizing the physical condition before the surgery is crucial, and fitness from a concerned specialist, like I mentioned, is very important. And very crucial is to explain the risk and the benefit of the surgery in concordance with their general condition, and obtaining proper consent which is appropriate for that particular patient. Now that's very important because certain patients fall into high risk not only ocularly but also general condition wise. So it's important to be a king in ophthalmology rather than to be jack in anesthesiology or general medicine. So take their support and go ahead with treating them. Thank you.
Thank you, Niranjan, for focusing on the finer aspect of assessing a patient. And